We have about... All right. Episode 1, Tim Talk Live. How you feeling?
A little nervous, but
Yeah,
I'm
we'll
feeling
get through it. I mean, you got a killer red dress on, so I think that's the best way to start.
Yeah, to match the killer shoes too.
That's right. That's right. Yeah, we had to do extra preparations to make sure that the shoes got in the shot. Okay, great. So I have a lot of things that I wanted to chat with you about, but I'll follow your lead too as we go through the conversation here. There's a lot of serious things I think we need to get into about like how mental health is being dealt with in healthcare. I think everybody knows that it's a huge problem and things that we have to manage, and your work in substance abuse is obviously going to be directed in that path. But let's get started with you. So you started off as a nurse in the armed forces, correct? In the National Guard, is that right?
No, I was in active duty Army.
Active duty Army. Can you tell us about that? Like how, because I imagine that's going to be a little bit different than what you're doing now. Because one of the things I love about you is that you've worked in SNFs, right? You've worked in so many different settings. Like here's a clinic setting. You've worked in the Army. You've worked at outpatient practices like Fuller right now that you're doing a lot of good work in and stuff. So I imagine you're an ideal person to talk about just kind of all the different types of settings that we see and how they're managed. So could you tell us about how you got started?
Sure. I became a nurse over 30 years ago. And from nursing school, I enlisted. No, I didn't. I commissioned into the Army because I had my bachelor's degree. I could go directly into officer candidate school.
Okay.
And went through training there. It lasted, I was in active duty for about a year and a half and then transitioned over to the reserves once I found out I was pregnant with my first child.
Okay.
So I stayed deployable for 8 years after I got out. And so 3 weeks before 9/11 occurred, I was discharged from service.
Okay.
I completed my service obligation.
Wow.
So, I was originally stationed at Fort Devens. Fort Devens shut down.
Yeah.
And as it was shutting down, I was departing active duty.
Okay. Wow. Interesting. So, I mean, what is that? So you had to go through boot camp and everything like everyone else, correct?
Correct. Officer boot camp. Yes. Not enlisted boot camp.
Okay.
A little bit different. It's pretty much, in some ways it's similar, the physical fitness, the requirements to go through boot camp and be physically fit to be a soldier, was still the same requirements. It's just that, you learn the modules that you learn in the classes that you take are geared towards officers.
Okay.
And being a leader. And
what kind of services were you providing there?
I was working in the hospital at Fort Devens, and I was doing basic med-surg kind of duties as a registered nurse.
Okay. So you didn't work with any kind of mental health type of services back then?
No, not back then.
Okay.
No.
Great. Okay. So now we transition from Army to where?
So from the Army, I worked in the pediatrician's office for a number of years while I had my children. And then while I was there, I noticed that there was a lot of things that I could say, hey, I know what this is and I know how to treat it. And why do I have to wait for a doctor to come in and tell the patient that that's exactly what it is and this is how we're going to treat it? Right. So I decided to go to grad school.
Awesome.
So 3 kids, in tow. I went to grad school, with the support of my husband. As crazy as it was, with the support of my husband, got through grad school.
Yeah.
And completed grad school. It took, I did the program. It's a 2-year program. I did it in 3 years because I had 3 kids.
Sure.
And worked full time while I did it and had the kids. And
And were you Northeastern? Is that where you went?
That is where I got both my degrees.
Yeah.
So I got my baccalaureate degree and my master's degree.
Okay. And I have some, hold on, let me see. I have some getting used to all this stuff too. I got this cute little banner for you. Boom.
Boom.
Medical director. So now we have ADAPS. And you've done a lot of stuff.
Clinical director.
Clinical director, sorry. Not medical director.
It's okay. Clinical director. Yep.
We don't want
anybody.
That.
I mean, it's just a play on words. However, people, when they see the word medical, tend to think that you have MD after your name.
I
And
see.
this clinic is without an MD. We are fully nurse practitioner run, fully support and back nurse practitioners. And, you know, we certainly have colleagues that are MDs that we can collaborate with if we need to collaborate with them.
Sure.
But, you know, the state of Massachusetts has afforded us the ability to
fantastic.
practice independently.
Yeah, there's been like since the emancipation, it's so great seeing these MP-led practices because they're different. And I feel like a lot of people, not to go into a MP versus MD piece here, but like, I mean, people typically, a lot of people really gravitate towards the discipline of nursing. They typically find like the bedside manner is more enjoyable. I know from a documentation standpoint on my side of things, much more ordered, much more like doctors tend to be a lot more messy about things and not super well ordered and need a lot of help with that stuff. And most of my nurse practitioners are pretty well organized. So what is it that drove you to get into the addiction side? So you've done a lot of stuff in addiction medicine. You're carrying that into here.
Correct.
You've worked with a lot of people who've gone through very troublesome things. I had a post a couple days ago on LinkedIn. I don't know if you saw it, but I had my daughters in it, and they were saying, I asked them, I said, what would you ask? And one of them said that, you know, is there good money in it? And I laughed because the reality is that, not that it's funny, but the amount of funding, and we were talking about this before we went on, the funding that goes into it, that goes into mental health is abysmal here. It's disgusting. And a lot of people are dissuaded from even going into, most of the social workers that I see are so unbelievably passionate because a lot of them know that the reimbursement they get is not really going to be great for the amount of loans they take out, the amount of years they put in to get their LICSW or the LMHC or something like that. So,
well, if they're doing it for the money, they're doing it for the wrong reason. Because,
I agree.
Because I've been open since October and I've received zero.
Yeah. So let's talk about that too. I mean, here's the thing. Like, I agree. Everybody should be passionate about what they do, especially in healthcare. And when you see people who are business first in healthcare, it's always bad. Like, it's always bad for treatment. But at the same point, folks need to be reimbursed appropriately. Like there should be, if anything, if there's any segment of healthcare that we should have an incentive for, like great reimbursement for, it should be in mental health. It should, because we're in a really sorry state right now in this country with where we are with services and with everything that we see going on. We know that so much of that is fueled by people being desperate and not having the resources. To take care of
And I think, you know, I think that the insurance companies make it a little bit more difficult because, you know, a lot of the patients that I saw when they booked their appointments with me were because they got my name from their insurance company. But then when I submitted claims to the insurance company, my claims got denied because for one reason or another, they got denied. That it wasn't appropriate, that people needed a referral to come and see me, but they were picking me as a primary care doctor and they were making visits to me as their primary care provider, and you know, gave them the service, gave them the high quality level of care. You know, spent over an hour with everybody. You know, filled out, put my claims out, and received no cash for
which
those
is
visits.
insane. And I think, and the Mass Med Society just put up something on LinkedIn the other day, and then I kind of went off on my comment to it. But they're trying to push hard for new standards for prior authorizations, but whether it's prior authorizations, eligibility issues, where I don't care who you are, even if you've been doing like what I do in the billing world for decades, this is the most complicated process. And we expect patients to understand how to navigate the system. And so whether or not you're going to get billed, whether or not something's covered and we can take this plan and we can book this patient, they're not supposed to be obstacles in getting care. They you know, we should be facilitating to make sure that patients are getting the care and not fighting over medical necessity for things that are obviously necessary for these patients.
I agree. And then, you know, everybody wonders why we have overweight, overstressed, over mentally challenged society that we have, and why people are struggling, why people are turning to addictions in some cases, and overeating in some cases. You know,
what do you usually see for the history of the patients that you treat when it comes to addiction? What typically is it? Much more about like, are we looking at usually like social determinants of health, like their background, like where they were raised, or is it typically like, you know, how our culture is, things hitting them hard, where all of a sudden they're on hard times and they don't really have a hand to hold?
You know, I think that there's some misconceptions about addictions, and you know, addictions has no socioeconomic status. It goes wherever.
Yeah.
And, you will see it in any of the communities here in the South Shore. The town that we're in, Norwood, has its problems like any other town.
Yeah.
It is just, it's so talked about in Boston because you see more homelessness in Boston. You see people hanging out on the streets, so it's more visible and in the streets. But heroin's out this way. Cocaine is out this way. All of those drugs are out this way.
Yeah.
And like Boston, it just gets more difficult to know what's being mixed into the drug supply at this time. Some people,
Right.
when they come into the hospital and we do drug tests on them, or they come here and they swear they're only doing, I'm only buying coke. Well, you think that you're only buying coke, but drug dealers don't care what kind of surface they're mixing their
Right.
product on.
And the fentanyl.
Cocaine has fentanyl in it.
Yeah.
Fentanyl has cocaine in it, and marijuana it is laced with several substances too. You
Right.
know, and
But I imagine that's changed a lot since it's been largely legalized.
yes and no. I mean, you still
So
have
even in like if someone's purchasing something from like cannabis stores, they could potentially have it laced with something.
no. The cannabis stores are clean.
Okay.
Those are the ones where you truly. I see just cannabis products
Yeah.
When we drug screen patients. But it's the people that are getting it that aren't of age to go to the cannabis stores.
Oh, okay. Okay, that makes sense. Because I was just starting to think like that must largely be kind of going to the wayside with the push to legalization. But so for minors that are trying to get access, they're still getting it on the street.
They are.
Interesting. Okay.
They are. And they're starting quite young.
Really?
Yeah.
Well, and there's been a lot of changes with adolescents, right? Like alcohol's down, cigarettes are down, right? But
cigarettes are down, but vaping is up.
It's through
so
the roof.
Nicotine is,
It's still
yeah.
still prevalent.
Yeah.
And my oldest daughter says that they see it in their high school all the time, like in the bathrooms and stuff, and people think it's really cool and all that good stuff. And they won't do anything that's not smoking because you can't see it. It's not cool.
Right. Right. And the scary part is that now marijuana products come in vape. So there's the oil. So, somebody can say to the parents, well, I'm just doing the nicotine, I'm just vaping, trying to pass it off as nicotine when in fact it has,
Now, how big of a priority is this though? Like, cannabis obviously is not going to be something where, cocaine and crack and things like that those will kill you, right?
Right. But, you start cannabis early enough, then you play around with the normal natural growth and development of the brain, and it really affects people. Right. And, some people say that they're using cannabis because they're sad and depressed and stuff like that, not realizing that cannabis actually makes that worse.
Does it?
It does.
Okay.
It does. And I know that there are certain dispensaries that say, well, we got this to cure depression, this to cure. But again, you got the 12-year-olds.
Well, it's like anything else. It like takes you away from reality, which is never good. I was just having a conversation with someone yesterday about how like, nobody ever got rich off of drinking more beers and stuff like that. Now I'll like anybody else, or like myself, I should say, that's I love having beers over the weekend and stuff like that, but that's never really going to be something that puts you into a better situation. It's always nobody gets rich off unless you're actually brewing it. Like actually my brother runs a brewery, so he does that jerk. But so that's really interesting. So now, are you a native of Norwood? I know you're from this area, right?
Born and raised.
Born and raised in Norwood. So is that why you chose to do ADAPS here?
Yeah. I've always wanted to stay in my community. The only time that I left Norwood was when I was in the service.
Okay. They say that about Norwood people. Do you know Norwood people? You probably know this.
We're in the Guinness Book of World Records, yes.
So this is a true thing. So you're in the Guinness Book of World Records for people who are born here and die here, like for the country.
Yes, and people that marry within the town too.
It's kind of weird.
I did not.
Think? What's like? I love Norwood.
Yeah.
They have some good. I like Napper Tandy's, for instance.
Yeah.
That's a good place to hit up. And well, no, we don't have Patriot Place here, but we're pretty close to it.
Yeah.
But there's a lot of good things in Norwood. I used to actually, when I got into healthcare, I cut my teeth with on a lot of work over at Norwood Hospital. Yeah. May she rest in peace. And
may she resurrect.
I hope. Do you know there's a big campaign for that now?
Yes.
That started up. So hopefully, God, don't get me started on Stewart. My Lord. But it's great that you're creating something here in a place where you grew up. I did something similar. I set up a pediatric practice a few years back in Stoughton, my hometown. I mean, I flirted with going in other places, but there is something special about trying to give back to the area that you grew up in. So here's another question now. You're providing PCP care,
Correct.
addiction medicine care,
Correct.
but also IV therapy care.
Right.
So I should say it this way. I see these as three very different things. So you
They are.
homogenize them somehow. So is there overlap here? And if so, can you explain like just the...
Sure. People certainly come in for primary care services with me, but the biggest concern that you're seeing with a lot of primary care patients, unfortunately, is weight. So, we reel it back and we take that and we reel it into the wellness. So the IV wellness and all that kind of go hand in hand. And, as nurses, as nurse practitioners, our approach to anything in medical is from the avenue of wellness.
Okay.
How do we keep you well? How do we get you well? And we don't always, we will treat problems just like any provider will treat a problem.
Yeah.
But our goal and our intent is to keep our patients healthy so that they don't develop the diabetes from the overweight. They don't develop the hypertension. They don't develop those secondary things that come from being less well.
Right. It's like preventative medicine, basically.
Absolutely.
Okay.
Absolutely.
So how do you do that?
So, coaching, counseling, guiding, trying to work with them where they're at. I have one primary care patient. She's in her 50s and she came to me not significantly overweight, and nowadays, you're normal weight, overweight, or obese. Those are the categories. Certainly you can be underweight as well, but we don't see that as often. And it's that very fine line. And, as a person who has struggled my whole life with weight issues, I have a passion for helping people to try to find something,
Awesome.
But you have to remember that, and everybody has to remember that it's not about just going to the gym and working out. It's 80% of weight issues stems from what goes into your mouth.
Of course. Yep.
And only 20% really stems from what you're doing at the gym.
Sure.
Obviously, you can change that percentage a little bit based off of how you're working and how you're trying to find that balance. But unless you're accountable for what goes into your mouth, you're going to fight a losing battle. And that is my thing, and I say to everybody, I will work with you and I will give you treatment however you want and with whatever is within the scope of practice that I am allowed to prescribe and treat you. But until they can show me accountability for the minor things, I don't jump to the latest fad.
Right. Yeah, there's so much in there. Like, so I recently, I went through like a depression for a couple of years recently, and I put on like almost 50 pounds. And then I got a septoplasty, which is my husky broke my nose, believe it or not.
Yeah.
Little jerk. And she, so after a couple of years, I realized I wasn't sleeping well. I definitely have sleep apnea and stuff like that. And I don't know if it probably wasn't caused by that. I probably had it, but so I get the surgery, and then afterwards she says, what are we going to do about that sleep apnea? I said, I imagine you want to give me some dental thing or some CPAP or something like that. She said, generally that's how it goes. And I said, but you tell me what the problem is, and we all know what it is. I'm like, I'm a big boy, I can take it. And she's like, you could stand to lose about 20 pounds. And I was like, right. So I told her, I said, why don't we do this? Set an appointment for September, which is 4 months after surgery, because I knew I wouldn't be able to work out for at least a month.
Yeah.
And I said, give me some time. So if I come back to you in September looking like this, I will follow your lead.
Yeah.
And if I come back and I'm at like 212 or something like that, I said, then why we'll do like a sleep test or something like that. And she said, I like that. And, I think it's because I don't believe, like, I know Ozempic's going crazy out there and a lot of people don't care about the side effects of it.
Right.
And that concerns me. And I like what you're doing here too, is this very naturalistic type of an approach. I think that's important. But I think from the counseling, like counseling is another thing, not just from mental health counseling, but also weight counseling is not well reimbursed. Most insurance companies don't reimburse for that. I think that's garbage too. You talk about the things that are probably most needed. If there's anything after mental health, it's weight counseling.
Right.
Because so many people struggle. But then you also have skinny people who are completely unhealthy with terrible diets, and nobody seems to pay attention to that. I think the BMI is kind of garbage too. I feel like there needs to be a better way to ascertain how people are doing
Mhm.
and educating them on difference between like that fats aren't necessarily a bad thing, but they
Right.
have to be moderated, and protein and
Right.
carbs and all that.
And there are so many wonderful apps out there that everybody can use
Yeah.
to kind of see how that goes and how that plays into their lives and stuff like that.
Right.
I don't market any one particular app. I feel that you find something that's going to work best for you. What the thing about using the app or having an app, it only works if you use it.
Right.
And trying to do a retrospective input into an app isn't the ideal way to
Sure.
keep track of it, because well, I think I had 4 chips when really 4 chips was like a whole bag of chips. And trying to do that recall, because
Yeah.
life stresses in a day can get in the way, and you may have done a little this and a little that and
Yeah.
forgot about all of
Of
those
course.
things. And if anybody's like me and they have any sort of sugar product around them,
It's gone.
Yeah.
And then you'll even lie to yourself about it. Never mind the app.
Yeah.
Yeah, that's interesting. Yeah, accountability is so big and very challenging and difficult to manage. That's really
that
interesting.
and water, drinking water.
So yeah, because usually when I think I don't know, I get concerned with the water thing and the hydration piece, because I feel like, so I used to be very large,
Yeah.
and then I got into, my brother helped train me to get into running, and then I was able to shed a bunch of weight and stuff like that, which was great. But I mean, what they were saying to hydrate, and a lot of the studies came out of this university that I found out was funded literally by Gatorade themselves, because who else would want to have something like that? And I get because I feel like, I don't know, I look at it like this: if I'm thirsty, I'm probably dehydrated, and if my pee is clear, then I'm probably overhydrated. And generally speaking, as long as you're not, if you're doing something like, because people would run a 5K, and think that they could eat a pound of pasta to carbo load for that or something like that, and it's like, that's not really that far.
Right.
You're not really. So I agree that hydration is extremely important. The amount of people I know that get headaches every day is huge, and I know that's a big cause of it. But
as my bariatric doctor said to me, that sometimes we eat in place of drinking, when really what we are is our body's craving fluids. So if we drink and we're still hungry, then our body needs.
I've never heard that before.
Then our body needs something to eat.
So you're Italian though, right?
I am.
And I wouldn't start the show off with anyone other than an Italian. So I mean, like, eating is the essence of life for us. So this is it's very difficult to get away from. And what you do here too is, because when I first saw IV, and a lot of other people who I've talked to, the first thought that we have is, this is a hangover cure place.
Yeah.
And although I imagine you can help out with that.
Well, I certainly can.
There's a lot of other things that you do here. Like when I came here, you gave me a fat loss and an energy boost thing. And I think somebody came in here earlier for something similar. So explain to me that piece of it, like, and how it's natural and not something that's like these Ozempic things that could potentially be, these quick fixes.
So the vitamins that we have here, there are so many. I mean, I thought I knew a lot about vitamins until I started studying vitamins, so that I can incorporate them into the practice. But you have the B12s and the B complexes and vitamin C's. People are very familiar with those kinds of vitamins. Vitamin B12 is a great source of energy.
Yeah.
Well, vitamin B6 is a great source of helping to lose some weight.
Okay.
Some of the amino acids and the lipoproic medications are used to take the fat off your body. So currently I have a product that combines minerals, lipoproic acid, and B12 and carnitine, which all work together to boost metabolism, to suppress the appetite. In particular, carnitine is a big one that suppresses that appetite, and it suppresses that food noise that people talk about. It's like, I'm always thinking about what's going to happen for my next meal, or maybe I should just go have a little snack now, or whatever. And people that are coming in are getting it. One woman that I had this morning says, "Hey, we're at that 4 to 6 week mark, and guess what? I'm feeling the difference."
Interesting.
She's feeling, they feel the difference in the way their clothes are fitting, they're feeling the difference. You know, one person said, I can finally wear my bra and not have an extender on it, you know, to make it a little bit looser.
God, I know that feeling. Oh.
So, you know, it's just, it's some of those little quality things that, that help. You know, and I remind everybody, you know, it can't just be about this one shot, you know, and based off of how people work out is how often I recommend getting that shot. You know, somebody
Which
who's
is also
not going to
gonna be
work out, I'm not going to give them the shot more than once a week because they're not burning it.
Right.
You know, so it's,
Okay.
you know, if you burn the shot, if you're burning off that shot, then you can get the shot more than once a week.
Okay.
You know,
but you have to feel confident. How do you gauge that? How do you know who to trust and who not to trust with that with your patients?
you know, people don't want to lie.
Okay.
You
So
know,
generally speaking, you think
yeah, I think they're pretty forthcoming.
Okay.
You know, and I'll say to them, I said, don't over exaggerate because, you know, I need the truth in order to calculate what's going to be the best for you. And, you know, because they are vitamins, some of them are, you know, there's no harm in giving them, you know, twice a week.
Too much, but there's no benefit and they're just going to waste your money. And
And, you know, a lot of the product that I carry is not what we call the lipophilic, meaning it doesn't attach to fat.
Okay.
So it's most of the product that I carry is stuff that you're going to pee out.
Okay.
You know, especially vitamin C and stuff like that. So, but you know, you combine these vitamins in different ways, and you can have a vitamin that helps support your immune system. You can have a vitamin that supports recovery and performance. You know, for bodybuilders, you know, help muscle recovery and things like that. Things that you can pregame with, you know, if you're gonna go running and you want to get extra hydration and stuff like that, and to feed your muscles a little bit better, you can prehydrate.
Okay. Okay. Interesting. Let's switch back to the addiction medicine piece for a second here. So a lot of people have addiction issues going on in their families and stuff like that. You don't, of course, have to answer this. You can, of course, pass on any of these questions. But is there something that personally happened to you that got you into addiction medicine? Is there like a reason why you were like, this is something that I want to be a part of? Or is it just really your empathy for how rampant it is?
It's my empathy. You know, when I first became a nurse practitioner, I swore I would never do geriatrics. I swore I would never do psychiatric, and I swore I would never do addiction.
And you've done all of these things.
And those have been the areas that I really gravitated towards. You know, in terms of working with geriatric patients, I mean, I've worked in nursing homes, so I've had a lot of exposure with working with, you know, chronically ill geriatric patients. You know, I got exposed to that right from my very first nurse practitioner job, you know, working down on the South Shore in Norwell and that area down there.
Okay.
You know, I was in at a primary care office in Norwell. A large part of the commitment to that office was that you had 50% of your time in the office and then 50% of the time in a facility of some sort.
Okay.
And he had multiple of them. So we went to multiple, you know, we went to skilled nursing facilities, we went to rehab centers, we went to assisted livings, we went to group homes. So gave me that flavor of that. And I've kind of continued it. And, you know, I've worked hospice. And so I have a passion for a good understanding for end of life care. So I'm not afraid to have that discussion with someone saying, hey, you know, while you're still healthy, let's think about a couple of things, you know, and start planting the seed of how people envision, you know, the second half of their life. And
that's interesting because those specialties that you're talking about, like geriatric, anything having to do with counseling, in my career, and I've been in this industry my whole life, not that I've ever been a clinician, but my clients who have had the closest connection with their patients have always been in mental health as through counseling type of work, and in geriatrics in the SNF environment, and even in the ALF environment, I would say as well. But a lot of like post-acute care stuff, you have more of a connection. Whereas, you know, and this isn't to change, you know, there are a lot of people who are very passionate about what they do, but the patient connection, especially for like surgeons, for instance, a lot of times they're not going to have that strong connection with their patients. It's oftentimes that they will. I mean, they're not any less passionate about what they do or anything like that. But like one of my clients, she was working at SNFs during COVID. And I remember one time she called me up and she was crying because she'd lost, I don't even know how many patients in a week. And that stuff is devastating. And sometimes when you work in the SNF, I mean, again, I've never actually done it, but I remember once I was really taken aback because I went to this group meeting somewhere up on the North Shore, and this NP comes in and she's just like, oh, Mr. So-and-so passed today. And the other one was like, oh, thank God. And I'm like, what in the world is this? And they went on and say how, you know, a lot of people think it's like soap operas, that they're going to get better after having a stroke. And that's not really something that happens. And that this person was lingering on for so long in pain for so long that they were happy that he finally got his peace
Yeah.
and stuff like that, because they are tied to him. And I'm sure there's always a sick sense of humor that you have to have in medicine for various reasons. But it's really interesting, like, that you come into this so passionately, just from, like, it just speaks, I think, to your empathy. Whereas I think,
because I got to tell you, before I worked with addiction, I probably did not have that empathy. It wasn't until I was really ingrained in it, and that was my focus. And all of my patients had some sort of addiction, until I fully understood and fully appreciated. And you know, at one point in time, you know, prior to getting into it, I probably would have, if you asked me, I would have said, well, methadone and Suboxone, you're trading an illegal drug for a legal drug, you know. Sure. But after working with patients that have been engaged in treatment, do well in treatment, I now understand Suboxone and methadone and the harm reduction and the lives that we save. You know, because people are on these medications. And, you know, that is every family's worst nightmare, is getting that phone call that, you know, somebody passed away because they overdosed. And if having them on Suboxone or methadone keeps it so that that family doesn't have to get that phone call, you learn to accept that. I know that, you know, harm reduction and safe use is not at the forefront of everybody's mind. But there has to have that, you have to have that understanding, you have to have that compassion, because it is a disease. It is something that needs to be addressed. And, you know, if you can't offer support to help that person try to achieve the best sobriety that they can, and meet them where they're at. And that's really what it is. It's about meeting them where they're at. Then, which is
extremely challenging, because where they're at is, I steal from family members, I do this, that, and the other, and I trust nobody because everybody has abandoned me. And like the program they had that they set up in Canada for the supervised heroin injection, that, you know, I did some work on the board over at Greater Lawrence Family Health Center, and I had never heard of this before I got into the FQHC world. And that is, at first I was like, this is ridiculous. What? And then you realize that it's the only way to build any kind of trust. And like you're saying, reduction is better than overdose. Like less harm is better than more harm, which is ultimately your jobs. But
and not judging, because, you know, there are plenty of people that are on Suboxone or on methadone that still have that use. They have use, but it is significantly less. They've gone from 10 bundles a day to 1 or 2 bundles a day. But, you know, it does improve their life. And, you know, there's so many people that are on methadone clinic that they get up, they go to methadone clinic in the morning, and then they go to work and have a productive day. You know, some people need that check-in once a day. And, you know, I mean, now we're making methadone more accessible. Still hard, but more accessible.
Is Suboxone now in a ejection form now?
There is this, it's called sublet.
Okay.
And, you know, people that wish to be on that can certainly be on it.
I would imagine that's a big push to get it off the streets, right? As something to sell.
You know, it's mixed reviews, and some people like it and some people don't. You know, it's a difficult injection because of how it's given. It is given beneath the skin, so it makes like an encapsulated injection, and you know, you can't rub it the wrong way. You can't, you know, there's some parameters around giving it.
I didn't know that. Okay.
I personally don't administer it. I've ordered it, but I haven't administered it. Usually I have a nurse that can administer it for me, and, you know, has gone through the training on how to do it.
And can give like the advice and all that stuff.
And, you know, I mean, I work with the drug companies, and like, okay, Rosemarie, when are you going to get on board with giving it yourself? I have no fear of giving. I mean, I work with needles all day long, you know, so there's no fear of that. But, you know, that is, it's kind of hybrid, because even with the sublet injection, people still need to have some Suboxone, because when they're first getting started on it, there's the first couple of days where it hasn't kicked in, so you need the Suboxone to help bridge you till the shot kicks in.
Okay.
And then sometimes that very last week of it, because it's good for 28 days, that very last week of it, sometimes people are saying, oh, I've got some cravings or whatever. And so you want to stave those cravings and help prevent them from going to the street drugs. And so you supplement with some Suboxone.
Okay. And how about Vivitrol now?
Vivitrol works well for some people.
Because what does that do? That induces vomiting or something?
Vivitrol is all about blocking the cravings. Okay.
Oh, okay.
It does not have any opioid to it.
Yep.
Okay.
Right.
So it just completely helps to block the cravings and stuff like that. People don't find it as effective. I've had very few success cases on Vivitrol alone.
Okay.
Vivitrol works well with alcoholics, and better with alcoholics than it has with.
I think that's what I'm thinking of where I've seen it used. Okay.
Yeah.
Right.
Yeah. So but Vivitrol and naltrexone pills. Do people drink above their Vivitrol? I mean, if you have somebody that wants that alcohol bad enough, they'll drink through it.
Sure.
Like anything, and but it offers the better chance of not getting as inebriated in some ways because people don't have that.
So again, just taking a step towards being more healthy.
Right.
Oh, it's got to be such a bitch. I can't imagine how hard because this is a very challenging field. And now let's get into the real pain points. Yeah. So we can talk about how easy it's really easy for you to set this whole place up, I imagine, right? This was a joke. Setting this place up.
Let's talk about the speed bumps.
Let's talk about reimbursement. Let's talk about before we started, I was bitching to you about how when I was running that pediatric practice, how United would not pay the $6 for our teenagers to have a mental health check, and they were trying to pass that along to the parents. And there was nothing that probably infuriated me more that whole time with the pediatric practice until then. And we ended up just writing all of those off because it's like we're not going to bill the parents for this, and we still have to administer it because these kids need that.
Right.
So, what do you find that is the most infuriating piece of getting? I mean, this place is. I walk in here and I'm just like, this place is gorgeous. If like the people at home have not seen, well, maybe we can we'll put up some shots or something like that in some of the rooms. But we have one before. You gave me the whole upsell treatment and stuff like that. And that was an amazing experience. Things that I didn't even know, like that what is it called? Alpha stem?
Alpha stem, yeah.
Alpha stem, and things like that I think a lot of people could benefit from. But before we get to that stuff, what you actually do here, tell us about what has been your major pain points or frustrating. What are the things that aren't fair? Because there's so many people who I would love to see start up a practice, but they hear these horror stories and then they don't. And I feel like they're people who could be players like you.
Yeah. So, getting this spot, this location, was a gift. It was the gift because my brother, who is a chiropractor in the community, works with a physical therapy and a physical therapist who has a practice here in Norwood. And he's moved around, and my brother has moved around in various spots in Norwood and has landed in this building in the past 5 years. Actually, they preoccupied the space before I got the space.
Okay.
So
those are the folks right across the way here.
So the practice across the hallway. So Fred and several other groups were using the space. They moved across the hallway, and then this became empty, and it sat empty for a little while. And there's a vision of trying to create a collaborative care center.
Yep.
People come in and they talk about, oh, I don't have a primary care, or I don't have this provider. And so once I was able to lease this space, I changed it up, rehabbed it, made it my own, put my own colors in here, and made it what I felt to be warm. And I wanted it to be, this is not your typical doctor's office. It doesn't have that antiseptic scent to it. It doesn't have that feel to it.
Right.
We offer various areas of seating. We have recliners, we have swivel chairs, we have
aromatherapy, and
we have aromatherapy. But I tried to hit some of the bigger points. I made sure that I had chairs that could comfortably sit somebody who was overweight.
Yeah.
I made sure that I have equipment that can help for anybody that may have some impairments. So my exam table lowers all the way to the ground so that somebody doesn't have to climb up a
I
step
love
in order
that.
to get onto the exam table.
Yeah.
My chairs are the wider chairs. So if somebody is wider,
Yeah, I think you're the first. Interesting. I've seen those chairs in there. I'm like, that's not really enough room for two people, but
no,
interesting. But like I don't think I've actually I've known about those exam tables that go up and down. I don't know that I've really seen one at any of my clients' offices yet. And I think you're my first. And those things are so important. I mean, the amount of intelligence they can put scales in them too and stuff
Right.
like that. It's great what they can do with exam room tables now.
So, I invested some money up front, and dipped into the rainy day fund to get some of the products that I really wanted to get in here and the quality of products that I really wanted to get in here. When I first occupied the space, I had everything all in this one space, but as the month continued to grow, I kind of have pushed a waiting room out to the front of the office. I pushed the reception desk out to the front of the office to make it more inviting.
The setup's beautiful. That looks like so natural for it to be over there.
Yeah, so to make it more inviting to have people come in. We had some different plans at first, myself and the physical therapist, on how we were going to utilize that space, but some things didn't fully pan out. So since I occupied the space in October, I have reached out to a neuropsychologist friend who now occupies space here.
Yeah.
I have reached out to a psychiatrist who occupies space in here.
Yeah.
The goal is that we're hoping to get a podiatrist in here. I know that we have had an acupuncturist who came in and toured the space. So it's to try to get as many services as we possibly can into this one space so that people can feel like, hey, I only one building, I can see all my specialties.
Right.
Right. And not be in such far distance from this specialty to that specialty. We're 3 floors, elevator accessible, but we're trying to keep everything on this ground level. So
Awesome.
Like anything, we offer patients the right to choose who they want for a provider or whatever. We make recommendations. Like I have made several recommendations for chiropractic care, or I have made recommendations for physical therapy. And I say to the patient, you are welcome to go wherever you want.
Yep.
I am putting in your referral. I can tell you that I am familiar with the providers across the hallway.
Yep.
And
Yep.
I don't think that you'll do poorly by picking them as your choice.
And you let them know if they're not a good candidate for the people over there, you would
support them
going
elsewhere.
We have let me see how my tech is over here. So we have hold on. This is I think what I was supposed to do when you first came in here. But here's like a little snapshot of the website for people. It doesn't have the whole thing. Now I wish I did put the whole thing in there, because at the bottom of your website you have this
banner.
This banner that is all diced up, and it has different providers in there, or just like advice and different, like whether it's a message or it's a picture from like your Instagram or something.
Yeah, I hit the jackpot with my most recent web developer and tech person. She is doing an amazing job. She's listening to some of the things that I have to say, and I will shoot her an idea of something, and she'll take that and develop it into a blog or develop it into a post to get the word out.
Is she local too, or?
No, she's local by telephone, like most places.
Yeah.
Like most people. I mean, she physically lives in the tri-state area. So
okay. Do you want to give her a plug?
Yeah, her name is Crystal Ergang. She became my web developer after the woes of having a web development fail, and that I wasn't really happy with. But like many things, you think you make the best decisions picking services and things like this right from the beginning.
Right.
I thought I picked the right biller and credentialer.
Yeah.
Learned how that did not work for me. Then I redid the process over again, picked another billing company, and they decided 2 months after taking me on that they no longer wanted to do billing. So
it's insane.
So as you know, I mean, I said, that's it. I'm staying local. I'm going local with my billing services, my credentialing services. I found a company, your company, DMS, to fix my credentialing nightmare. So because I hadn't received any pay, I started seeing patients in the office in October, and I hadn't received a dime of reimbursement because things were not.
Credentialing was such a mess.
Yeah.
But how would you know? And that's the thing. And it's like there are bad actors in our industry that torpedo any practice, never mind like a brand new one coming up. Like the fact that you're still even surviving that and are still here
Yeah.
is a testament to you and probably to the patients of your husband. How's your husband doing with all this stuff?
You know what? If it wasn't for his patience and his support, because I can't tell you how many times I wanted to throw in the towel and say, "What did I do this for?" But then I remember what I did it for, and you know, I've been very fortunate. You know, but like anybody that starts a practice, you don't give up your day job until completely.
Do you think there's any way you could have avoided those things? Like what you're saying sounds like you interviewed potential vendors that didn't work out. I mean, is there any advice you could give if anybody's watching that wants to start up their own practice and they're getting like kind of cold feet at the moment? Like, how do you figure out which vendors you want to work with?
Sad thing is some of it's trial and error.
Yeah.
Because I asked the right questions, like, can we make sure that I'm credentialed with these companies? And the one question that I didn't make sure that I asked is, can we make sure that I'm credentialed as the right kind of provider with these companies? And so I was credentialed with many insurance companies, but I wasn't credentialed as a primary care provider with some
I would
of them.
strongly disagree with you on that, because that is the job of the credentialing company. It is like, you're not any more than I'm not expected to know how to treat your patients. Should you know how to do my job? Like, that should be if someone's doing rev cycle management or if somebody's doing credentialing, it's what are you doing with your practice? What's your vision? It's getting to know the client and understanding what they're doing, not just like checking some stupid little boxes. It's because you don't know how to do credentialing.
Right.
So the experts should be leading the way on that conversation.
Right. And, I made my first selection because they came at the recommendation of an organization that I was part of. And so
interesting.
So I didn't think that I'd go wrong by picking them.
That stuff's tough too, because sometimes organizations have these relationships because a company pays them, if we pay you X amount of money, we're going to be one of your preferred partners, where there's no vetting done.
Right.
You know what I mean?
Yeah. That was the same issue with my original website company. I chose it because it was recommended by an organization. I've learned my lesson.
Yeah.
I've lost some money because of both of those selections. But now I'm on to bigger and better things.
Good.
As you know, I've been working with Tracy, and she has figured out the mess and has got me back on the right track and kind of cleared up what kind of patients that I can see.
Yeah, I'm sure she's watching that right now, and I got to get all them. I got to get all the DMS people over here now.
Starting Friday, Andrea and her team will be taking over my billing, and hopefully we'll be able to submit my claims appropriately so that I can start seeing some reimbursement for them.
Right. And at least give you immediate feedback if there's any issues and stuff like that. And we'll meet after this too and talk about how things are starting up operationally.
Yeah, but I was also, in some ways, I guess I went against some advice of when somebody said, no, you don't want to do IVs and injections. And I said, but I do want to do IVs and injections. So the IVs and injections have been able to afford me some income, because those are all cash based.
Yep.
I don't have to wait for insurance companies to do that. And so I've been
Would you ever do an insurance based I mean, you'd be doing like nephrology services, I guess, if it was something like that.
Yeah. Right? There were certain things that I can certainly, if somebody came in sick and they were terribly, terribly sick and they were dehydrated, I could hang some fluids on them and charge that back to the insurance company as treatment. But the other stuff that I offer for IVs, that's nothing that I would ever
You don't have to go
wanted.
through all the bullshit of the insurance company requirements of everything from documentation to, like you were saying earlier, like referrals and crap like that. Like you can just get them in and get them out. You get cash in hand. You don't have to wait like whether it's 2 weeks for the primary and another month for the secondary to pay up and stuff like that. You can just get the job done. And that's I always tell people, as much as it would hurt my business, like the more you can swing a cash-based thing, like a lot of people do in concierge stuff, which is tough in this environment, but that stuff it's great because it's just immediate cash and no requirements of, making sure you have the LCDs right, that this diagnosis code matches up with that service. And,
Right. And, I welcome people that don't have insurance, and if they want to work out a cash, a fee-for-service kind of a plan, I'm not opposed to taking on those patients. I think we need to open up healthcare to everybody, and try to meet them where they can financially meet us. And, have them understand, I'll do my best to provide you the care that you need,
Right.
and meet you where you are financially. But that may tie my hands. Like I may not be able to order certain testing because it's just outside of that financial. But if I can offer a cheaper way to get to that answer, then we'll offer the cheaper way to get to that answer.
Okay. And what's the typical patient experience here that you have with, let's say someone's coming to you and you're their PCP? So do you loop in these other services with them, or what's the typical
I do.
relationship?
I have quite a few of my primary care patients that have that have come in, and their goal has been weight loss. Some people do want to push for that, the Wegovy, Ozempic, and Tirzepatide. I'm not opposed to it, but I do set a bar. You've got to meet this requirement for a few months before we even talk about that kind of a drug.
What do you mean? Like what requirements? Like
my requirements of tracking your food, tracking your water, tracking your movement.
So you try to get them to figure it out on their own. Because, well, that's the thing too. We're in the U.S. where people just like, if you can give them a magic pill,
right?
Because what did we have before? Like, what was it, 80s and 90s? Ephedra or something like that. And it seems
the
like, is that what it was? Yeah. And it seems like every 10 to 20 years, there's another wonder drug comes up, and people take, because I know a lot of people have GI issues with Ozempic, right? So, but a lot of people don't care if they think it's a pill, and now they don't have to eat right, and they don't have to go to the gym or wherever, and it fits like a very simple process to not bother their life. Whereas, I mean, I think the reality is that people should be bothered, and they should be made uncomfortable to set up healthier processes to get better. So like I don't know. I mean, what are you seeing with your patients who have taken Ozempic? Do you think that's, so you look at it as like a fallback basically?
So I have one patient who comes in to me once or twice a week to get the Lipo-C, the product that I was talking about, the lipoprotein, the mineral, and the carnitine. She gets that once a week. In addition to that, she gets something called NAD, nicotinamide acid, real long name. Regardless, I mean, I know it's one of those ones that's kind of like all the craze right now because a lot of celebrities are talking about it.
Oh, I think I've heard of this.
However, it works with like brain fog. It works with memory. It works with energy, and it really gets down to that cellular level. Yeah. And she has found an incredible difference. She said that one of the things, how she measures that it's working for her, is at one point in time she would have stressed out about having to go away, or even if it was like for a short trip, she said she would get overwhelmed. But since she started using NAD, she doesn't have that angst anymore. It's like it's not as overwhelming in her life. How
often does she take it?
She's getting it twice a week.
Twice a week. Wow.
Because that's not one of those ones that is dependent upon exercise.
Okay.
The lipoproic stuff is dependent upon exercise.
And the NAD, is that something does that gradually get better, or is it something where you take it twice? Like you have to, if you don't take it, then within a day or two, you stop feeling that fog come back?
I haven't heard that.
Okay.
And some people will extend how long they take it, and say, you can certainly go a week or 2 weeks without it, but it's one of those drugs where it depends on how you get it as to how often you want to make the recommendations for it. So if they're getting it by a shot, they can get it up to 3 times a week is what, the recommendation of it.
Yeah.
But it's in a smaller dose. If someone were to get it via an IV, then they can get a higher dose of it. But that is probably the one IV that takes the longest time, because at 250 milligrams, it takes 2 hours to infuse. And at 500 milligrams, it takes 4 hours to infuse. So it's like, how much of your time do you want to expend? Mm-hmm. So everything that I offer in an IV form can be given in an injection form.
Right. Which is how, you.
And there are some people that just want that. Hey, I want that. I want a quick boost of energy.
Is there a big difference between the two? Like, is it better to get the IV? For any reason,
it's all a matter of preference, really.
Okay.
The big thing is that with IV or IM, you're avoiding the gut process, and so it doesn't have to go through your gut to get absorbed into your system. So it's more of a direct entry. And
because I'm kind of like, I always need to be on the move type of person, so I like the injection thing more. Right. Whereas I think some people might like the experience that you have here. of like that machine you have in the other room, that chair. I've never been like, I felt like an astronaut. The thing like takes you up back. It like compresses your arms, which I've never had before, and had like things underneath your feet. I mean, it's an amazing thing. And then you had the Alpha Stim on me,
Right.
and like I feel like that with the IV is probably, I don't know. I think people could come here and just are probably coming here and just feeling like, oh, like they just had an amazing spa day.
Right.
I wish I had the attention for that, because for me, I just like to get my stuff in and out. But but that's good that you have the offerings for whatever you do. Now, how much time are you typically spending with your patients? Because obviously, you know you don't get reimbursed for extra time with patients.
Right.
But for you to get to the relationship with a patient to have conversations about these other things that you have, you must know them better than a typical PCP does.
So I allow myself 60 minutes for an initial visit.
Okay.
Regardless.
Yep.
I give myself that 60 minutes. And really, based after that, it will drive what I set for time-wise.
Okay.
I mean, if somebody's coming in for a sore throat, then yeah, that can be 15, 20 minutes.
Yep.
I don't need that much time.
Yep.
But if I'm having them come back for a follow-up based off of something that was discovered on initial exam, then I'm allowing 30 minutes for a follow-up time.
Okay.
Because you've really got to grab that understanding of what have you done since we last met.
Right.
And you can't do that in
But
15
you're also
minutes.
taking that quarterback route too, where you're saying you're also in your head considering all these potential people you could refer your patients to.
Right.
And that's another frustrating thing, is that that stuff should be incentivized. There should be reimbursement that goes towards you for stuff like that, because there's a lot of PCPs who don't do that.
Yeah.
They just come in unless you straight up are telling them, I'm only here because I have a UTI, I need a referral to such and such place.
Right.
They're not typically doing that next step that you're doing here.
Right. And that's why I think that this practice stands out a little bit differently from some other ones.
Yeah.
I mean, are there other IV drip places, other injection places? Absolutely. They're growing by leaps and bounds.
Yeah.
I don't know where they get their product from. I don't know. I do know what some of their prices are, because some of them do post what their prices are. But I try to offer the lowest possible price.
Okay.
I need to make enough so that I can pay my infusionist.
Yep.
And pay for the supplies that it takes to give somebody this care here. I find that my upcharge is very little.
Yep.
When compared to,
which is surprising too, considering I'm sure you're right now in a hemorrhaging state where you're trying to get to that break-even spot, right? And that, because that's the pain points of the startup process.
Yeah. I mean, when I first opened up, I ordered product, and guess what? I had to throw it away because it expired in so much time.
Right.
Because I wasn't getting.
You have to forecast that, and that's got to be extremely difficult to do. So where do you see this? I mean, I'm sure there'll be surprises to come, but like, what is your vision for the future? Because I'm sure it's already changed from when you first started this up.
Yeah.
But,
I mean, I'm just really out here just to try to, I just want to get the word out there. It really is a unique primary care setting. Our focus is on wellness. Our focus is on keeping you well and keeping you safe, and not being afraid to come in. If you are somebody that suffers from addiction, or you have a family member that suffers from addiction, it's safe space to talk about it. It's a safe space to try to bounce things off of each other and get some advice.
And what about counseling services?
So I do collaborate with several mental health providers. As I tell most of my patients, most of the providers that I refer to will be nurse practitioners.
Yeah. Why is that?
Because we love each other. We respect each other. We expect the time that we spend with our patients, and we can appreciate that same thought process of keeping people well, and not just treating an illness and seeing a patient for their illness.
Right.
Because back in the old days, it was like, oh, that person's addicted. No, it's a person who suffers from substance use disorder. And it is a disease, and regardless of what kind of substance that they're using. And I have my my Rolodex full of MDs as well.
Yep.
I have great MDs that I have collaborated with in the past, and I continue to collaborate with them.
Right.
And I'm not opposed to putting out a reference to any kind of provider at any level of their service.
Yeah, like if you have a patient that for whatever reason. I don't know why they would come to you if they didn't want to have a MP working with them, but if they prefer, like, because I know some folks who prefer an OD over an MD or something like that.
Right. You know, and right now my challenges are with the older population.
Yeah.
So, you know, that will still be a little bit of a struggle. I think that will still be my challenge. And hopefully Medicare doesn't drop me again. So they make me go through the process all over again. Because when people are calling and making appointments, like some of the older folks will ask, well, who's the doctor of this practice? And I'm like, I'm sorry, but there is no doctor of this practice.
Right.
This practice is nurse practitioner run, and you'll only get a nurse practitioner visit out of this. We'll provide you the same care. We assess, diagnose, and treat just as MDs do.
Yeah.
But you know, when you start with us when you're younger, we take a different approach, and we do take that approach.
I think that's a big thing that a lot of folks don't know, how like physician assistants have a different path than nurse practitioners.
Correct.
And you know, it's just what fits the patient best. What kind of mentality do you like the most? Can you speak to what you were just saying about Medicare, having to re-up with Medicare? Because that's something probably a lot of people don't know about, and especially for startups, is very important, because we were taken by surprise by this new policy they have.
So, you know, I mean, obviously I established my LLC a number of years ago, worked as an independent contractor. A lot of the billing that I've done in the past has been because the companies that I've independently contracted with wanted to have everything go through their company.
Yep.
So I provide the service, but they bill through their company. So I didn't have the need to bill Medicare under my own numbers. I mean, I billed them as a provider, but the practice was billed under the practice of the company that I was working with. So ADAPS Healthcare itself didn't bill, but Rosemarie Spada did.
Right.
And Medicare sent me a notice recently saying that they had withdrawn my privileges, billing privileges. And
because it was 6 months, I think, right?
Yeah.
And they gave you no notice?
No notice, because I hadn't submitted a claim in 6 months' time.
Right.
So I tried to defend that and try to let them know that, you know, I just established a brick and mortar, just starting to get patients out there, have started to see patients, but there have been some issues with, you know, credentialing and different things. And not for lack of trying, but the generation that has Medicare is a generation that struggles with not having an MD.
Right. Okay.
So they rejected my rebuttal and forced me to reapply into Medicare, which I did the very next day, and just found out today that I've been accepted as a Medicare provider again, effective back to that date. So I need to make sure that I have some sort of a claim that gets processed as through a Medicare provider, through ADAPS Healthcare, because I still continue to submit claims through Rosemarie Spada.
Right.
But
you need to attach
right now through Fuller Hospital, I bill under them because I see their patients. And
so I don't have a problem with there being a policy of, if someone seems like they're inactive, to clean up their books. But the fact that they didn't reach out to you, like I was saying, I think before we went live, and we're going to have to close this up in a minute, but like the revalidation process, they typically give a 90-day heads up, a 60-day, a 30-day. And then afterwards, they're like, you've expired. Here's what you need to do to get backing of like 30 days or something like that afterwards. And they send that notice to your place where you're seeing patients, to the home address of the provider. So in case, for whatever reason, they're not getting their mail at the practice address, whichever. So they're very diligent. And I think it's great that they do that, because cutting off somebody from anything on the credentialing side has a major impact on any practice. But giving you no notice on that, I think is, and I'd be interested to see if anybody else has had that. I don't know if we have any comments. Can't post comments in some destinations. Okay, I don't know if we've got any comments coming in here or not, but I don't know. But I think it's very, like, again, it's another, they might not be aware of it, but it's a very bad actor type of feeling that you get from that. Because why would you just shut people down? There's got to be a lot of people clamoring about that right now.
Yeah, and no sooner did I get that pulled, you know, that I was losing my Medicare, do I get a phone call from a local practice?
That's right. Yeah,
from a local practice.
I think you called me right up, and you're like, "Can I see this patient too?"
That's
fine.
And then, you know, here in Norwood, with the shutdown of Norwood Hospital, and then a lot of these medical groups that have pulled out of the town, you know, the need is even greater. And
and I think glad you brought that up too. So I mean, I'll probably post something about this too, but there's a there's a push right now to bring back Norwood Hospital in at least some kind of capacity.
Yep.
And so I'll post something about that as well, because I know that there's an organization that's really pushing for that, which is really
Yep.
great. So despite the problems that we're seeing with these insurance companies, you're still alive, you're still kicking here,
I still am.
looking for new patients, I'm sure.
I am.
Anything else that you want to throw up here before we close it out?
No, I mean, I just think that, if you decide to join this practice, or if you decide to utilize any of the providers that are collaborating within this practice, that the care that you'll get is top notch. I don't think anybody will be disappointed, whether you're coming in for chiropractic care, physical therapy, occupational therapy, neuropsych, because, Dr. McCardle is now doing ADHD testing and things like that.
Oh, I love that work too. I might want to chat with Melanie on one of these at some point in the future too, because a lot of people don't know about that work. And I'll tell you that hits me personally, because my oldest daughter's been tested on that twice. And I know there's so many people that aren't even aware that this testing exists, that could also have kids who suffer from things like OCD or autism or
again, it's one of those services that is poorly reimbursed, and hard to have insurance coverage for. So, sometimes if it's an academic testing, sometimes the school systems will kick in the funds to have the academic portion of it paid for. But a lot of the testing that she does is not necessarily insurance covered, and it is out-of-pocket expenses to
my first time around was out of pocket, and it was not cheap. And then the second time we were able to have insurance actually paid for it, thankfully. But it's something that needs to, and so we see this with a lot of payers are coming up with what they determine to be medically necessary. We're seeing a lot more regulatory pieces coming out from state levels and federal levels, stating that you have to keep behavioral health, mental health services at the same level of medical necessity as medical. A lot of places aren't doing that. We're seeing lots of denials and a lot of bad actors. But there's a bill I was going to bring up, but we don't really have time for it anymore. But there's a Medicaid bill that's right now hitting on the federal level. What is it called? It's like the Medicaid Bump Act. So this is something that was just introduced, I think, on July 25th, so like a week ago, and it is being sponsored by a Republican and a Democrat. So bipartisan push. So hopefully that gives it a good start. But basically looking at increased funding. We've seen a couple states have moved. So usually social workers get paid about 75% of what the MD rate is, what a psychiatrist would be paid for. But psychiatrists don't perform counseling services anymore. For the most part, they're doing med management stuff. And that's not a shot. It's just the reality of it. So for counselors, are trying to push them now from 75% to 85%, which puts them at like the NP/PA type of a rate, which is great.
Which should be 100% for the NP rate.
I don't disagree with that either. I mean, I understand when it first came out why they would, but now you don't have any practices, you don't have any hospitals or anything that are effectually working without NPs. And I would throw PAs in there as well. And whether you're a psychologist or a social worker, they're like across the board, there needs to, and the question that the problem is that most of the folks that need this care that you're delivering for, like whether it's for addictions or mental health services or like what Melanie's doing, a lot of those folks are on Medicaid. Medicaid is terribly funded. We're seeing it just recently getting a bit more of a gutting, and the reallocation, regardless of how you fall on things politically, there's such a big need for funding into Medicaid. And even though Medicaid has been a huge money loser in a lot of ways, I mean, you just depending on where you go on places, but for the federal government. But I think we all know it's such an investment that we need. We can't have the most vulnerable people not getting psychiatric care. They have more reasons than anybody else to be on a substance, to fall into a criminal life and things like that. And that's what we really need to work for to change around. So I really hope people do get their act together and push this.
Yeah, I agree. And I definitely think that, that our society needs to have a better understanding of the roles of a nurse practitioner. And, nurse practitioners are a growing field.
And DNPs, there's a lot of DNPs popping up now too.
And, nurse practitioners aren't the answer to primary care. We are the future of primary care. We are going to be the primary care providers in the future. And with the ability to practice independently, you know, you'll start to see more and more of it. And,
Yeah.
you know, we support each other in every way that we can. And
Yeah.
so, you know,
I love that. My pediatric practice partner was a nurse practitioner as well, and she's absolutely amazing. And yeah, I'm very much on that bandwagon for you that there needs to be the acceptance. I mean, you still see a lot of physician organizations like IPAs, CINs, or PHOs that aren't even still not accepting nurse practitioners. And it's like, how are you possibly going to have groups that have nurse practitioners working there that are seeing these patients that can't be part of these physician organizations? It's provider organizations. You need it, and all that stuff is all getting so antiquated. And you know, I really hope that we see a lot more of that change. And I love that you're a strong push for the MPs. I love that, as everyone should be. So, okay, well, anyway, thank you so much for being my first guest. This was awesome, and we got some other stuff to chat about. So we're gonna sign off. Everybody who paid attention and who stayed here, and feel free to throw comments on. And I can't see. Oh wait, I think I got a comment in here. We have a comment. What do we have? Thank you, Rosemarie. Oh, thank you. So Mitch Galvin. This guy is he works at Stonehill College.
Nice.
He's a professor over there, and he's been gracious enough to allow me to come in and do some like classes with the students at time. I haven't connected with him for a while, but we did some stuff back when I used to be big into the MGMA. And I still like the folks over there, although they've evolved to this other organization called the HLA now. And Mitch and I haven't caught up in a while, so I probably should reach out to him. But the students there are awesome. They have a great healthcare program over there.
Fantastic.
And so he basically is like he's the main healthcare guy over there. He teaches the students, but he also leads the program. So he's a fantastic guy. So thank you very much, Mitch. And but if anybody else has anything they want to throw into the comments, we'll end up posting this thing. If it doesn't automatically post, I don't even know how this thing works. And but then if you don't mind maybe checking it out in a week or in a few days and responding to any of them, and if you're unable to for whatever reason, I'll make sure we'll get back. Oh, we got another one in here. Lauren, this was fantastic. Awesome. Great. So we got some, so it's good. At least somebody's watching. So that's something.
Fantastic.
All right, guys, thank you very much. We're going to do our super dope outro created by my friend Matt Ducharme from Design with Charm. Let's see, how do we end this? Thanks, guys. We'll see you next week at the next one. We have, I believe, Rich Napolitano, who is this bigwig in the FQHC environment. I worked with him when I worked over at Greater Lawrence Family Health Center, and he's doing a lot of very interesting things. But we'll start marketing him probably starting tomorrow.
Sounds great.
Thanks again, Rosemarie.
Thank you.